Thanks everyone for being here as we wind down to our last Virginia Opioid Abatement Authority Abatement Academy session for 2024. We're currently working on planning some more sessions for 2025, so stay tuned to our newsletter for that. Today, our focus is on how local governments are using mobile services to reach people when accessibility is a challenge. And with us is Monica Flora from the Piedmont Community Services Board to do this presentation today. So Monica is a licensed professional counselor and a licensed substance abuse treatment professional. She received her bachelor's in clinical psychology along with a secondary education teaching certificate from DeSales University in Center Valley, Pennsylvania, and a master's degree in human services mental health counseling through Capella University's online campus. Monica began her career as a counselor in a children and adolescent psychiatric facility in Pennsylvania in the early 2000s. 15 years ago, Monica entered Piedmont Regional Community Services Board as a case manager. She transitioned to several positions, including an ID&DD group home manager, psychosocial rehabilitation manager, outpatient therapist, substance use disorder treatment services supervisor, substance use disorder treatment coordinator, and is now the assistant director of the addiction and recovery treatment services for the agency. Through this position, Monica oversees substance use disorder treatment and recovery services across West Piedmont, streamlining 3 office-based addiction treatment clinics, including a mobile unit, substance use disorder case management, and the PACE to Recovery Program Emergency Department Bridge Program, Community Recovery Employment Program, Pathways to Recovery Peer Center, Substance Use Disorder Outpatient, Intensive Outpatient, and 5 recovery residences, including the Grace House for pregnant and parenting women with substance use. It is a passion of Monica's to participate in community and leadership roles to help facilitate transitional change. She enjoys learning the needs of the community and collaborating creatively and collaboratively creating solutions to meet those needs beyond the scope of traditional practices. A highlight of Monica's career is exploring treatment and recovery services beyond traditional brick and mortar offices, thus creating the mobile unit for Piedmont or Regional Community Services Board. So, well qualified for this. Thank you all for being here today. Monica, really thank you and Piedmont for allowing us to steal you for a little bit to put this together. And you are welcome to put questions in the Q&A as we go, and I'll kind of moderate those and figure out a time that makes appropriate to do those. If nothing else, we'll definitely have time for questions at the end. I guess before we get started, I do see one hand raised. Oh, that hand looks like it's gone back down. Okay, fantastic. So, Monica, to you, and take it away.
Thank you. First and foremost, thank you, Charlie, and the Virginia Opioid Abatement Authority for having Piedmont present today. I'm excited to do that on behalf of our agency. The first thing I wanted to share with everyone on today is that we certainly are not experts, and I want to acknowledge that this is growing across our state. It is incredibly exciting to see the mobile units and how each agency and CSB is doing it a little bit differently. Our unit, we started this planning back in 2020, and so I do want to acknowledge Mimi Sajat from Eastern Shore for her guidance and support, Jennifer Faison with the VA CSB for advocacy and leadership, and Greg Preston, who is the PCS Executive Director for Leadership, fostering creative interventions to help our community and going with us on these wild ideas back in 2020 of a mobile unit and leaving the office with a nurse practitioner and therapist. So today we are talking about preferred OBAT. I am going to start our presentation with telling you a little bit about our agency. Our mission with Piedmont Community Services Board is to help individuals, families, and the community to enhance their quality of life by providing a highly effective continuum of behavioral health services, including prevention, treatment, education, and support within available resources. Our vision is to reignite our passion for quality services to our clients by having a streamlined environment that empowers staff and sustains financial resilience. We cover the Patrick County, Patrick County, Martinsville City, Henry County, and Franklin County, which is also all of West Piedmont Health District. The population of individuals living in our four localities is approximately 137,000, with about 70,000 female residents, including 21,300 between the ages of 15 and 44. The median age for our region is 45.52 years for men and 48.42 years for females. The median household income averages $46,300. And we compare this to the overall median income for Virginia, which is $76,500. The percentage of children living in poverty averages 24% compared to Virginia's rate of 13%. According to county health rankings, Henry County, Patrick County, and the city of Martinsville are ranked among the least healthy counties with the lowest 0 to 25%. The population of focus is a rural family and individual Southwest Virginians across the lifespan with limited means to travel to Piedmont, Piedmont sites for preferred OBAT services. So I want to highlight that the individuals that we're working with are coming from incomes within their households that are well below the average. And we have quite a few people living in higher rates of poverty than the Virginia average. In addition, substance use and overdose rates in the Piedmont region are among the highest in Virginia. In 2021, when we started to launch this program as well as our PACE to Recovery ED Bridge to Treatment program, overdose visits to the emergency department were more than 800 in the region for an average rate of 82 per 10,000 visits compared to the state rate of 66. Opioid overdose ED visits for the region is at a rate of 49 compared to 33 for Virginia, and regional stimulants overdose visits are 8.5 compared to 2.9 for the state. We also, during this time, recorded that the rate of neonatal abstinence syndrome per 100,000 hospitalizations in our Piedmont region more than doubled from 2012 to 2017. Particular regions of the PCS service area have higher percentages of uninsured adults, 17% in Henry County, and uninsured children, 7% in Patrick County, than the Virginia averages of uninsured adults, 12%, and uninsured children of 5%. Access to primary care physicians varied greatly among the Piedmont region and is consistently lower than Virginia. The state of Virginia averages one primary care physician per every 1,330 individuals, while Franklin County averages 2,680 to 1, Henry County 1,760 to 1, Patrick 3,530 to 1, and shockingly, the city of Martinsville averages 12,900 to 1. So this begins our need, why we were requesting funding to start looking at how do we get services out of a traditional brick and mortar office? How do we get to individuals that cannot afford transportation, that we know are struggling with housing, that we know we can't refer to a primary care physician because there's not enough of them? So Piedmont, we created an arts ecosystem. So again, arts is addiction and recovery treatment services. And what we did was we stopped looking at addiction treatment as a continuum of prevention, treatment, and then you land in the world of recovery. We started to put the individual in the middle, and we started to figure out specifically what services are needed for that individual. Thus, we created our definition of the arts ecosystem as an interconnected network of interdisciplinary teams within a community that enhance an individual's lifelong process of healing physically, mentally, spiritually, and emotionally. Because as we know, addiction is a disease. It requires medical intervention as well as behavioral health. And we know that addiction has a negative impact on an individual's physical health, mental health, spirituality, and emotional health. So preferred office-based addiction treatment. I want to take a couple minutes and talk about what is that. So we call it OBAT. The acronym for office-based addiction treatment is an interdisciplinary team approach to treating addiction through a combination of physical and behavioral health medication, addiction treatment, along with social and environmental support. An OBAT should be a recovery-oriented and strength-based approach to treating the whole individual. And it's driven by ASAM 6 dimensions. ASAM is the American Society of Addiction Medicine. It is the guidebook. It is true of everything that we follow, and how we do things comes from the American Society of Addiction Medicine. So I put for you the 6 dimensions so you get an idea of when we're working with an individual, whether that's in the office or on our mobile unit, the areas that we're assessing to help this individual. The first dimension is acute intoxication and or withdrawal potential. So I wrote this as if you were assessing an individual, we would be looking at the areas of their past and current experiences of substance use and determining withdrawal potential. We know for many individuals that use opiates and derivatives of that the withdrawal is terrible. And honestly, that is one of the reasons that we see folks continuing to use, and it's to avoid those terrible feelings that they have within withdrawal. So it's very important for us to know when the last time was that they had used and where they're at in that withdrawal process. Dimension 2 is biomedical conditions and complications. In this area, we ask the individual to think about their physical health, medical problems, and physical activity and nutrition. Again, as an OBAT model, we're looking at the whole person. So it's important to note what are their physical and medical issues that they identify, or have they been to a primary care doctor and had a screening recently? Many of our folks haven't been since they were children. Dimension 3 is emotional, behavioral, cognitive conditions and complications. So with our individuals, we're talking about their experience through their life, their thoughts, emotions, and mental health. We treat that at the same time that we are treating misuse of the substance. It's important for us to understand what came first, the chicken or the egg? Do they have a history of mental health, or is their mental health a product of using some of the substances that they have been? And often we find the answer is both, that they have complications, but often there are underlying mental health concerns. Dimension 4 is readiness to change. This area identifies what the individual is motivated for and their readiness and interest in changing. It's important to know what motivates our individuals when they're coming to either our office or the mobile unit. Sometimes that is, I don't want to feel this way anymore. I don't want to go through withdrawal. I don't want to be so sick. I want something to be different. And so we take that and we run with it and we figure out what do they need as far as information and how do we boost them on to the next step of change. Dimension 5 is relapse, continued use, and continued problem potential. In this area, we address concerns that the individual might have about continued substance use, mental health, or a relapse. If an individual returns to use, it often tells us that something in their life wasn't working. Maybe the support they had wasn't enough, or they had started to take medication for an addiction treatment, but some of those things they hadn't worked through in their life were rearing their head. And so we needed to start looking at some different treatment interventions, such as therapy. And dimension 6 is recovery environment. This life area explores the individual's living situation, the people, places, and things that are important to them. We often find that when we get an individual that comes into services, their family quickly follows them, or close relatives, or neighbors, or friends. And this excites us because this means that an individual's recovery environment is becoming healthier when we treat the whole family. We often have referrals from Department of Social Services where a child was in need of services through Department of Social Services, and thus their parent or their caregiver needs some substance use services. And so it's important for us to treat the entire family unit and the whole person. So who can practice an OBAT? I'm not going to read this to you, but basically a credentialed addiction treatment professional is the language that is used by the Department of Medical Assistance and the Department of Behavioral Health and Developmental Services. There are a variety of different people that are considered a credentialed addiction treatment professional. You must have one as part of your OBAT team. And for us at Piedmont Community Services, that is our nurse practitioners, either our licensed social workers, our licensed professional counselors, or our licensed psychiatric nurse practitioners. Additional staff who practice within the preferred OBAT setting are included, but not limited to, certified substance abuse counselors, otherwise known as CSAC, or CSAC supervisee, someone who is under supervision but has not obtained their official certification yet as a CSAC, and a CSAC assistant. All of these are eligible to provide care coordination services under a preferred OBAT, and a certified substance abuse counselor can also, under appropriate supervision, do group and some individual counseling. Pharmacists can be a part of this team, registered nurses, licensed practical nurses, and of course, one of the keys to our continuum, our ecosystem, is registered peer recovery support specialists. So what do you do on the unit? I'm going to tell you shortly. I'm going to show you our unit. We're going to talk about it. But beforehand, I want you to think about what are the services that you have in a preferred OBAT in the office, and what do those services look like on a unit? In our office setting, we have medical appointments, we make referrals to primary care physicians, we have treatment of chronic issues, we have prescription for medications for addiction treatment and behavioral health symptoms. We have addiction treatment, which is provided by a licensed therapist, a resident in counseling, a supervisee, or a counselor with a certified substance abuse counseling certificate. We have care coordination in the office. So this is an individual who provides both case management services for our folks to obtain benefits, help link to individual resources in the community, referrals for additional medical providers, support to find housing, employment support, and they serve as the hub. They serve as that team member that's right there in that ecosystem with the individual to ensure that the individual's progress and needs are addressed in the interdisciplinary team meetings. Office-based addiction treatment, as I mentioned earlier, combines both medical, behavioral, social, spirituality, all into the recovery ecosystem. And so it is important, and there are guidelines among the regulations for Department of Medical Assistance that you have interdisciplinary team meetings. So everyone comes to the table to discuss the individual, to discuss their progress, to discuss their strengths, to identify barriers that they're having in treatment. And then also it is run by that ASTAM criteria. So we're looking at the areas that the individual is working on, and then that care coordinator takes that information from the interdisciplinary team meetings and then meets with the individual, and they discuss that and continue to create treatment plans. I will also say that Piedmont Community Services has their formal interdisciplinary team meetings as recommended or required by DMAS, but we also invite the individual to our interdisciplinary team meetings because we want to ensure that the individual is a part of their treatment and their treatment team. Peer recovery support, which I identified earlier, is such an important part of this ecosystem. A person who has experiential knowledge of substance use and/or mental health, who works alongside the individual, creating a plan for recovery and providing support and advocacy. So this individual comes to the team meetings with the individual. They help to participate while we're on the unit and in the office. So a mobile unit is an extension of your office-based addiction treatment. So when you have your services registered and are approved by the Department of Behavioral Health and Developmental Services, if you wish to pursue a mobile unit, there's then a process through the department where you then register your unit and your staffing and the interventions you're going to be using. And so anything that you do in an office setting, you can then do on your mobile unit. So Piedmont has decided that all of these services are going to follow our individuals onto our mobile unit. So I want you to take a minute. I shared with you our statistics, and I shared with you some of the difficulties that our community experiences and some of their barriers. I also want to brag about our catchment area and show you the beauty of it. This is Cahays Mountain in Franklin County. And when our team was designing our unit, and we thought, what do we want Piedmont to look like? What do we want substance use and office-based addiction treatment to look like when we go mobile? What do we want people to see? And what we decided was that we wanted folks to see our community. We wanted it to look like home. We wanted it to not look sterile. We wanted it to not look as much like a hospital setting, but something that they were like, huh, what is that? I'm curious. I'd like to go on that unit. So we commissioned a local photographer, and this is the picture that we chose that you will see in a second is the wrapping of our unit. Again, to talk about our need for mobile services, talked about the need for substance use in general. Now, the need for mobile was that in 2021, when we started applying for funding through the state opioid response grants and through the department, Piedmont Community Services was the only MOUD, which stands for Medication for Opiate Use Disorder provider in Franklin County and also in Patrick County, and then in the rural areas of Henry County. At that time, Martinsville City had approximately 2 MOUD providers outside of Piedmont. So these were the folks that were at the time prescribing Suboxone and Naltrexone. At the time, we had 1 of the 2 that were in Martinsville City that also prescribed methadone. Piedmont, historically, we have operated 3 separate preferred OBAT clinics. Intentionally, we have 1 in Rocky Mount, we have 1 in Martinsville City, and we have 1 in Stewart, Virginia. And we did that because our catchment area is so large that it would be too much to have 1 clinic and expect the different counties to come to it. There's not really a central area for them to come to. Back in 2020, we launched the Pace to Recovery ED Bridge program between Piedmont and 2 local emergency departments, which are Carilion Franklin Memorial Hospital and Sova Martinsville. And what we found was we were meeting with the individuals that had overdosed. They were starting a prescription there in the emergency department. They had 7 days worth of medication. They had peer support that was engaging with them, but yet maybe they came one more time to Piedmont. And then they were falling off the radar. And we knew it was COVID. We knew that there were stipulations. We tried to reduce barriers. We were doing almost all telehealth. Even over at that time, there was the ability just to have phone visits for psychiatric care. But yet, we had a hard time getting our individuals. So we decided to do a little bit more research, and the reoccurring barriers for our individuals to reach our preferred OBAT clinics were access to reliable transportation, cost of fuel and transportation, housing. So in one week they were living with one friend, and the next week they're living with family, and the week after that maybe they had to go to a different catchment area so that they could sleep. And then limited virtual options due to lack of service in rural areas. So many of the places that we go to in rural Franklin County and Patrick County don't have cell phone service. So if we were offering a virtual option, they weren't able to take advantage of it. And then the reality is that in our catchment area, it was easier, quicker, and sometimes you could just walk to gain access to substances to misuse than to go to treatment and receive MOUD at the CSB. So you may be prescribed at the emergency department that first dose and get a 7-day prescription, but you didn't have insurance to fill it. And then you didn't have the ability to get there to have it refilled. You didn't have the ability to get on telehealth to see your provider. And so what happened? You started to experience withdrawals. The quickest release for those withdrawals was to continue using. So that was where we said we've got to do something different. And we met with the Department of Behavioral Health and Developmental Services and the SOAR team back in 2021. And we applied for a state opioid response grant to build, actually, it wasn't prefab, we built it, a mobile unit. And at the time, we chose Farber Specialty Vehicles in Ohio. Again, side note, that was where Eastern Shore had gotten their mobile unit, had great success. We followed their lead. In this picture, you'll see myself, Terry Mills, who is one of our therapists, and Cindy Shively, who is our psychiatric nurse practitioner. Yes, we have masks in that picture because it was right after, the heaviest time of COVID. And we had a total award of funding of $400,224. I want to mention that because the units are completely customizable, that was the figure that we came to with the funding that we were awarded. But really, you can go far above that, and you can go below that depending on what your needs are for your agency. As we were developing the unit and we received the funding, we began quickly to develop our interdisciplinary team, which includes our clinicians, our nurse practitioner, and our IT team, so that everyone was involved from the very beginning of discussing what did we need on our mobile unit to be successful. So building the mobile unit. I am sharing with you the blueprints for our particular mobile unit. It is 34 feet long. We chose to have a container, which is that back area, which I'll explain what all those compartments are, that is on top of a chassis. Farber Specialty Units went with Ford. The reason we chose that was because if the vehicle was in an accident and it was more of an RV style, or it looked like sort of the same styles as a UPS truck, we understood that if the front end had significant damage, it would actually damage the entire unit. Whereas where we have many deer, and there's potential that anyone can get into an accident, if the front end of this vehicle and the chassis was damaged, we're able to take off that container and put it on a different chassis. So that was the rationale for why we went with this design. The top picture is the passenger side when you're looking at the vehicle, and the bottom picture is a bird's eye view looking down into it. So I have broken the vehicle into 3 different arrows. When you enter the unit, you go through the blue arrow. There's an entry door. You enter into an assessment area where we have our care coordinator sitting. They may do pretty much anything you do when an individual walks into an office. We check insurance, we look and see if there's any fees, outstanding bills. We update consents. We do a lot of engagement activities. If there is a need for their medical forms or something that needs to go out to a PCP, or we need to request records from a PCP, our care coordinator is doing that. We chose that there is a desk, and you'll see a chair in this blue, where the blue arrow is. This is where a care coordinator sits, and next to it is a bench seat that the individual faces the care coordinator. We also chose to have a little galley at this time, or in this section. We have a refrigerator and a microwave for our staff while they're on the unit. And there are 2 pocket doors separating the blue arrow unit to the black arrow unit and the green arrow unit. That allows for relatively confidential space for when an individual is finished meeting with their care coordinator. They then go into the Black Arrow unit, which is our treatment suite. We have a full bench, which is 72 inches long, and we have a pull-down table as well as a TV screen in there for telehealth and 2 rolling chairs. The unit for therapy is large enough that you could have a small family. You could have easily fit 2 adults on the 72-inch couch, 3 if they're relatively petite. And then again, we have the 2 rolling chairs for additional space. When you come out of that pocket door and go across the assessment area, we then enter where I put a green arrow. This is our medical suite. In this, you'll see the color orange. This is where we do have an ADA accessible lift that comes into our unit. The entire unit is not ADA accessible. We could not do that with all of the equipment we put in our unit, with couches and desks. But we did make the medical unit ADA accessible for an individual. And if we do have someone that requires an ADA accommodation, then we'll do all of their services in the medical part. We have a rotating medical chair, and then we have a flip-up counter. That is where our nurse practitioner sits. We have a jump seat, which means the seat is typically folded. You pull it down, and then if they have an individual, a significant other, caregiver support that's with them, they can sit in the jump seat. Sometimes our nurse practitioner and our nurse tag team some of the visits, and so the nurse will sit in the jump seat. And then at the end of the unit, on the back side, we have a sink, and we have there's compartments upper and lower throughout the unit. There's all of the medical equipment is kept back there, as well as the lavatory. There's a toilet and a sink. And then at the very back of the unit, there's a light blue little square, and that is a urine drug screen pass through so that the nurse can receive that on the other end. So I showed you a picture of our beautiful scenery in the Piedmont catchment area. This is what our mobile unit looks like. We chose to only have Piedmont Community Services visible on one place. We did that intentionally so that we would have a relatively confidential unit for folks to come onto. We planned 2 silhouettes of our Piedmont logo on either side of the vehicle. We did 1 picture that wraps around the front and the back. It's the same image, or excuse me, on both sides of the image. On the back of our unit is our Piedmont Community Services logo in true color, as well as our mission statement. And we have our Pace to Recovery Pure Warm Line numbers for how to access the unit, or if someone's driving down the road and they're curious what it is. That was intentional, because if an individual is curious about that unit, or someone says, hey, Piedmont's running a unit today, you should get in touch with them. We wanted them to first have contact with those that were working within the emergency department, in the office-based setting, and also on the mobile unit, for their first contact to be someone in recovery who can walk them through the next steps of what's going to happen if they would like to receive additional services. Then on the front of the unit, on the hood over the cab, it says Piedmont Community Services in white, and we have our logo. So services on the unit, I walked you through those through our blueprints. Again, we provide all services that we do in the brick and mortar office-based setting. We provide individual therapy on the unit. We provide care coordination, including case management duties. We have interdisciplinary team meetings on the unit. We have medical evaluations and nursing visits. All of our staff are trained in Rapid Revive, and we dispense naloxone on the unit. We have community outreach at sites. We do peer recovery services. And the staff that are typically on our unit each day are a nurse practitioner, our nurse, our OBAC care coordinator, a therapist, or a peer recovery specialist. We chose, when individuals were coming on the unit, that they would meet with their care coordinator first. They would then go for therapy. Once they finish therapy, they would then see the nurse and nurse practitioner. Um, they would then circle back around, and our OBAC care coordinator does the scheduling for them to come back onto the unit. Likewise, if we got a phone call from PACE to Recovery that someone called about the unit, someone is in active withdrawal, or someone was seen at the emergency department, they speak with our OBAC care coordinator, and that is who helps them to schedule to the next steps, whether it's better for them to be seen in the office, or is it more accommodating for the individual to be seen on the mobile unit. I will also mention, we do not carry any medications or cash money. There's no transactions that happen on our mobile unit. We have a car that comes, an agency car that comes alongside the unit when we stop. And at that time, if an individual needs a ride to go get to the pharmacy, if they've never had Suboxone before and we're truly going to do an induction, then one of the individuals, either the care coordinator or peer recovery specialist, will take that individual to the pharmacy, get their prescription, and come back. I will say the majority of individuals that are started on medication for addiction treatment, they usually do a home induction. Most of our folks we find are pretty familiar with it. From illicitly using it. And so they're pretty knowledgeable, and we find that we're able to prescribe, and then we follow up with them later in the day. And then we have a follow-up appointment on the mobile unit at a later time. So something that we went through here is part of our mobile OBAT team. We drove around. So when we realized we had this 34-foot vehicle, it was not going to go on every back road. There were bridges it was not going to fit under. There were grades in the road that were way too steep. And we wanted to figure out where were we going to help the most people. Like I said earlier in the slides, one of our biggest problems were folks were initiated on MOUD, but we had trouble with them following through with appointments to either see our prescriber or to then see some of our therapy providers. So we strategically chose that we were going to have different sites that we stop at. We have one site per day, and we operate in Franklin County, where we have the most individuals on MOUD twice a week. We stop at Henry County once a week, and then again in Patrick County once a week. The places that we stop are food pantries, local churches, community centers, and service stations. We did a lot of outreach to discuss what our mobile unit is, what services we're going to be doing on them, what that looks like as far as a commitment with us. And we did develop memorandums of understanding, MOUs, with the site owners, allowing Piedmont to stop at their site on scheduled days. We outlined the services that we were doing on the unit. And something I'll talk about later in lessons learned was putting into the MOU, if sites were agreeable, that we could use their facilities, so that we could use their lavatory wherever we were stopping. So mobile unit delivery, we started this process in 2021. It was September. Our mobile unit was not delivered to us until June 2023. Again, a couple years ago, that was due to issues with shipping, with cargo, if you recall, it just took a long time to get the necessary products to Farber Specialty Vehicles and then for them to get to us. So you can see our actual unit. It says on each of the cab doors, no medication or cash stored on the vehicle. Our vehicle is a diesel vehicle, and the generator that is also located on the unit is also diesel. And then here's a picture of the back of our unit with our logo, our mission statement, and our peer warn lines. Here are pictures of our unit. The picture on the left is our assessment area. So that's where our care coordinator sits. The fabric that we chose was navy blue, and there's a light green, hunter green in there. Fabric, we wanted something that was culturally appropriate and looked very nice. So we chose this for our individuals. We chose white granite countertops. So it is It's just looks nice. We wanted folks to get on there and feel that this was a service that they felt welcome to and something that looked nice. On the right is the galley where we have the microwave and refrigerator. And beside the galley to that right, that is the door to come into the unit. The picture on the left, you're looking at the therapy suite, the 72-inch couch. On the right, you will see there are upper cabinets above the couch, and the seat of the couch actually lifts up and there's storage in there. There are electronics to the right of that, and the wall that you're looking at beside the couch is the one closest to the cab. So it has all of the electronics for us to start our generator and operate our unit, electricity on the unit. All of the cabinet doors lock, just like an RV would, so that things can't shift around. Across from that couch, this is the therapy chairs, more traditional style therapy or a meeting type setting. The table that you observe can also fold down, which makes the room bigger. And here's our screen, which we can do telehealth, or when we do interdisciplinary team meetings, sometimes we bring in individuals virtually who are working in the office. The picture on your right is looking from the far end of the therapy suite through the entire unit. Here's our medical unit. The picture on the left shows a blue jump seat that I explained. If you pull down the cushion, you can sit in that. There is our sink, upper cabinets and lower cabinets. The upper cabinets, we chose to have a whiteboard finish on them, or we can leave notes if they're going from one site to another site. Sometimes they put on affirmations for our individuals or quotes. And then across from the jump seat is our lavatory. Then you see our medical chair. The medical chair sits upright, as well as it can lay down if there's an injection given. If there's a wound, something that the nurse practitioner can look at, so we can advise where to go for the best care. Up above the seat, you'll see a box with something black in it. That is a sanitizing, similar to what you see in primary care physician offices since COVID. It helps to sanitize the unit and the air. The last picture on the right shows you our ADA accessible lift that we keep upright, and then we can bring out of the unit to bring someone on board if needed. Here is a picture of our lavatory and sink. Again, the medical suite. So the impact on community. We average 5 to 7 clients per day. We noticed that we have more individuals that have retention and OBAT services. Some are going on over a year at this point. We see more individuals go from their initial appointment to a 10-day follow-up, within 10 days having a follow-up to 30 days and thereafter. Our individuals report satisfaction with the mobile unit and receiving multiple services at one time. We have increased community outreach, education, and naloxone distribution, and we have decreased stigma in our area. This is our mobile unit at our local Christmas parade. So we brought that through the Christmas parade. It threw candy. It helps our community to understand what we were doing and what the mobile unit looked like. Our budget, every budget is going to look different. We budget our personnel costs. So for all of those individuals I mentioned on the unit, we budget them in our mobile unit. Routine maintenance, last year we had about $2,265 in maintenance. We found that our local water and sewage disposal for the counties said it was easier for us kind of just to come and they refill our water and dispose of sewage than it was to create an MOU. So we were very lucky that they gave that opportunity to us, but that would be something that I would factor in your budget. Fuel, on average, we're spending about $330 a month. And that's because we go to one site and we stay at that site the entire day. That helps us to save on fuel from going from site to site. And then we also budget medical supplies and urine drug screens. Our annual cost is about 290,000 per year. But again, that can vary on what you want to have on your mobile unit. Lessons learned, expect shipping delays. Not everything comes quickly. We thought we would have our unit in 9 months, and it took about 2 years. That was completely out of anyone's control. But it gave us a lot of time to train and prep our staff that were going to be on the mobile unit. They were working in our office-based clinics. 2, navigating areas without cell services and Wi-Fi. We found that we needed a cellular phone in some of those areas that there's just no cell phone service. 3, finding sites with accessible facilities. Our experience has been that it's not desirable to always use the lavatory that's on the unit. So we found that we wanted to find sites where we could use facilities there. And then 4, storage on unit. We got very creative. In our bathroom, we house 2 6-foot-long tables that when we park, we put those outside so that we can have resources and do some engagement and care coordination outside the unit. We looked up a lot of RV sites about storage containers of where we can put things so that it doesn't move while we're on the road. And that concludes the presentation that I have. I recognize we only have about 13 minutes left.
Yes, thank you for that. Very informative. Lots of the ups and downs and the things you don't think about or don't expect necessarily to find. Appreciate you walking through that. So if anyone has any questions, please use the Q&A feature, and we'll work on that. Or you may use the raise hand feature, and then we can have you ask the question live. So we do have one question. I apologize if this has been covered, but does the driver need a CDL?
No, not in the state of Virginia. So, and I say that because I understand from VDOT that if we took our unit outside of the state, if we traveled with our unit, that this unit would require a CDL. However, there are no passengers that ride in the container of the unit. And there are 3 staff that can fit in the cab of the unit, that it falls within weight requirements as well as the amount of people on board that we do not need a CDL.
I think that's actually a really good question and a great
Mhm.
answer, because one of those things you don't necessarily think about is there are some areas of Virginia where getting from one part of your catchment area to another, it's faster to go through West Virginia or North Carolina to get there than to try to travel through through Virginia. So excellent, thank you. Another question: are there any zoning issues to work through with the mobile treatment?
We have not had any because it is an extension of your office-based addiction treatment. So once you have the proper credentials to be able to operate the preferred OBAT, and then you register your unit, we have not had any zoning issues.
Right. Does the CSB hire a driver, or does the staff assigned to the unit drive?
I will tell you, our not every staff wants to work on a mobile unit. I should have put that in our lesson learned. But I will say the majority of our staff were very excited. One of our supervisors for our treatment services in Franklin County and Patrick County also works fire and EMS. So when we got the unit, we asked if any of our staff were willing to be trained. And we went out to the fire department where there's the huge parking lots, and they ran us through the same training that you get when you run fire and EMS. So you understand how to maneuver the vehicle, back it up, do serpent curves. It was a great team building day. And our nurse practitioner and our care coordinator love driving the vehicle. I'm 5'2". I'm quite short, and I've driven the vehicle in heels going to take it to county administration meetings. It's really not hard to drive if you're comfortable. So we don't ask anybody to drive who is not comfortable, but we had plenty of people that wanted to drive, so we didn't hire anyone. If we would have hired someone, I would have also trained them to do engagement and to do some of those care coordination activities that we don't bill, checking insurance cards. Because when we're at a site, we're there for 7 hours. And so if we hired a driver, I would recommend finding somebody that can also multitask and do some other things for your unit.
Right. Yeah, great piece of planning to check and make sure your staff are feeling comfortable with it, or look at other options. We have another one. Great program. Do you have any type of referral pipeline from fire, EMS, or law enforcement? And where do the majority of your referrals originate?
Thank you for that question. We so when we talked about barriers for Piedmont and our clinics, we decided initially to focus on retention and services and eliminate barriers for individuals trying to drive to our office. So the majority of individuals served had come in through our office, and then we saw them on the mobile unit if that was easier and that reduced barriers for them. When we operated at Henry County Food Pantry, that was when it was like turning the hot sign on for the Krispy Kreme donuts. I mean, we didn't post on social media. We didn't have to. It was like the Piedmont vehicles here, the hot signs on, everybody come on and get your Suboxone. And we had great success. We filled up quickly. We are often at capacity, so that is something that we're trying to work with, is how do we increase our capacity on the nurse practitioner's schedule. So it's not how many people they can prescribe to, it's how do we adhere to the regulations that they must be seen weekly by a nurse practitioner who's prescribing their medication, and be able to have enough space on that schedule to accommodate that.
Right. Do you know what the average cost of the vehicle insurance is for the mobile unit?
Sure, we budget $800 a year for it.
Okay. What vendor did you use to design and build the vehicle, and what funding source did you use to cover the cost of this vehicle?
Sure. We applied for the state opioid response funding through the Department of Behavioral Health and Developmental Services. They completely funded our unit. There are prefabricated units that you can pick. We went to Farber Specialty Vehicles, which is located in Columbus, Ohio. And we drove up there and toured all the vehicles they were working on. And at the time, they were working on quite a few behavioral health units. Some of those were for the VA. We toured emergency services units. And at that time, we had a pretty good idea of what we wanted ours to look like. And again, outside of Eastern Shore, there weren't any other units operating at that time. So we completely customized ours, and Farber Specialty Vehicles helped us to do that the entire time. They helped us to pick out fabrics and flooring and recommendations of where telehealth should go and outlets, and they walked us through the entire process. It was pretty easy to design it with their help.
Great. Should also note that there OAA funds, either a direct distribution funds that city and counties have, the individual distributions or combinations into cooperative partnership projects can all be used for this. We have funded a number of projects that are either expanding or standing up mobile units throughout the state. Let's see. How did you get approval for taking the unit to a parade? Is this considered advertising? Someone's been wanting to do this, but has been getting pushback.
Can I ask approval from if we didn't need approval from the county, they said, yes, come on. They were, I mean, we were throwing candy out there for the kids. The county was excited. Piedmont Community Services works really well with our community partners. We have had it at festivals and fairs. We take it as an extension of a table, right? So if we're allowed to be a vendor and take a table somewhere with resources, this has been the vendor space that we have asked to have.
Yeah. Kind of a tool of outreach and engagement and making sure people understand the types of services that are available.
Certainly.
Did you do any marketing or promotion or advertise the locations and services? And did you run into any issues with building rapport or trust with patients?
Now you're going to ask if I had to build rapport with the sites, because yes, we had to do that. Um, Advertising, we did not. If we were going to operate our unit as a strictly walk-in basis, our plan was that we were going to publish with the Department of Health and our community partners at the hospital a standing map of where we were going to be. We fill every time we have openings, we fill them up so quickly. Either of those coming out of the emergency department or coming to our brick and mortar saying, hey, I need help. But what we find again is if they come to the brick and mortar, they're maybe able to do that one time or two times, but then they don't have transportation to stay in those services. So we did not do a lot of marketing. As far as building rapport with our individuals, I would say we were pleasantly surprised of how many individuals felt excited that there was a unit built for them. And when they walk on the unit and see how nice it is and how it's not a deteriorating school bus that we pulled out there, we found that individuals started to talk amongst each other. That sometimes, usually what will happen is somebody comes for an appointment and they bring two people with them. And then that's when they'll say, hey, I'm going to this unit, you got to come see it, talk to them, they're going to help you. The food pantry, we became a part of that network. And so individuals would stop by and say, hey, what do you got? And sometimes we had some of our little giveaways from HR that we do for promotional events. We have dog bones that we purchase that we'll give to the dogs that are coming through the cars at the food pantry. We do the naloxone, and folks will come on and they'll say like, yeah, I'm interested in naloxone. At one time we were giving out purple ribbons and we said, do you know someone who has experienced an overdose, or have you yourself experienced something like that? And most people know someone. So we said, please let us give you this purple ribbon. At that point, they said, what are you doing here? Once we talked about it, then they started talking about it. So I have no problem advertising. My fear is that if we did advertise, that we can't fulfill the capacity for the amount of people that would come.
Thank you. I think we got time for one more question. If there's anybody else that's got questions or thinking about, feel free to put them into the Q&A, and I will send them to Monica, and we can make sure they get out to you all later today. So I think our last question we'll go with here is, how many people are you able to serve in the Suboxone program through the mobile unit?
Oh, that's a great question. The answer to that is be flexibly accountable, follow the regulations, but also be flexible. There are days when we have clients scheduled every 20 minutes to see the nurse practitioner. And then when they have their therapy and they meet with the care coordinator and no one shows up until 1 o'clock. And so there's days that are heavier than others. We have days that we have folks that aren't showing up and we do telehealth. Or what we actually find is that sometimes even bringing the mobile unit out an hour away from our site, our office, is still too far for people to get to. So then we have our care coordinator or peer recovery specialist go pick people up and bring them to us. So on average, we're serving about 7 to 8 people per day. And then some of those, once they have stability, maybe they then get a vehicle or starting to get jobs, they transition to our office. So as a total, in Franklin County, we're serving about 150 individuals. In Patrick County, we're serving 15, which is huge for that area. I would love to serve more, but 15, we've got 15, that's exciting. And then in Henry County, we're serving about 20. So if you take 7 to 8 people a day on the mobile unit times how the 4 days that we're running, we've scheduled 24 a week, but sometimes we see more than that where they just show up and they come, and sometimes it's less than that.
Fantastic. Well, there we are, right at 11. I really appreciate your time and effort in putting this together for us, Monica. And there'll be a recording of this available on our website. You should get an email related to that when everything is done. And we'll also post the slide deck and send out answers to any other questions that come through. And like I said, keep an eye on our newsletter, our news updates. You can go to our website, which is www.voaa.us. Scroll to the bottom, put your email in, you're done pretty quick, and look for more Abatement Academy opportunities next year. Thank you all, and hope everyone has good holidays.
Thank you.